Hello everyone, we're going to be doing Spencer's technique for the shoulder as well as clavicle muscle energy techniques today. So let's say patient comes in, right shoulder injury. First thing I'm going to have him do is move through ranges of motion. So can I see flexion? Bring your arm up and then bring it back. And then he's like, ow, that hurts, right? Bring it across your body and then out wide. Good. Try to reach your back pocket. Cool. Now take your arm and do this. So let's say he's having pain with internal rotation, okay? So relax your arm. Now I'm gonna take him passively, right? Checking all those ranges of motion, across, out to the side, okay? Internal rotation, external rotation. Now we won't get into special tests in this video, but that's again, these are the ranges of motion you're working with for Spencer's technique. So let me have you lie on your side, head up here. So facing that way. Yep. So for Spencer's technique specifically, we generally start with flexion dysfunction. So if we're always bracing here, so if you want to come around to this side, so my hand, we call them Lego hands. So I'm framing out, bracing the AC joint here, just really for monitoring and safety purposes for the shoulder. Then I'm going to bring him into extension. Can you scoot closer to me? Thank you. And then here. So that's his extension barrier, or articulate this joint here, fighting for some more range of motion. If I turn this into muscle energy, I'll tap here and say push your elbow to your feet and relax. And a little bit more, push again, 3, 2, and relax. And again, and relax. So again, final stretch here. That's muscle energy for a flexion dysfunction. For extension, I'm swapping hands. I'm gonna frame it out and block this way, okay? Bringing up, keeping my hand against his elbow here, that's his flexion barrier. And again, I can spring, do articulatory springing, turn it into muscle energy. If you bring your elbow towards me and resist, keep going, and then relax. And again, 3, 2, and relax. So that's muscle energy there. Now for AD and abduction dysfunctions, I'm gonna block here, have his hand rest on my forearm. For an abduction dysfunction, I'm going into adduction. Gonna widen my stance here, and I'm pushing down. So push up into the ceiling. So this is that muscle energy and relax. For the abduction dysfunction, and again, and relax. You could do it seated too. Let me grab a stool real quick. So if he is adducted in the shoulder here, then we're gonna bring him into abduction, all right? So I'm gonna have you bring your elbow towards your feet. Good, and relax. So again, remember, do it again. Muscle energy is 3 to 5 times, 3 to 5 seconds, and relax. I'm just accelerating things for this video. For your articulatory spring here. Remember, my hand is still right here. If you want to come around that side, my hand is still blocking this AC joint, keeping it safe. All right, now we have circumduction with compression. So I'm compressing into the glenohumeral joint through the humerus. Here, you can do rotations. This is not considered muscle energy because it is a passive technique. So again, we're just doing some circular motions with compression. Now, with traction, in the Nicholas Atlas, they grasp here and pull up. You can even get away with doing this and pulling up too. Might make it a little bit easier. Okay, here, if I did it that way, again, it's traction, but I'm also monitoring here, all right? Small circles, big circles, clockwise, counterclockwise, like so, okay? All right. So next we have internal rotation. So if we bring, so this is the most, I would say, sensitive one for patients, especially if they have adhesive capsulitis, which is indicated for this technique. But you want to be careful because the moment you're really blocking here, this is very important, you're blocking anteriorly, okay? Now, when I bring him into more internal rotation by bringing the elbow towards me, you're gonna push out, back towards the back wall. Go, 3, 2, and relax. Again, so relax, and now we want to do a little springing here, right? But again, that's where patients can feel pretty sensitive, so be careful. For the last one, this is more of like an added technique to Spencer. So again, this is traction. We call it milking the deltoid. You can use your finger pads or interlock and do a scooping motion. I'm just distal to the acromioclavicular joint on the supraspinatus attachment on the humerus. And it's pretty targeted, like you can find a specific fiber you want to follow, but again, I'm just pulling towards me, okay? Now if I want to turn this into muscle energy, I'll have the patient push down on my shoulder, push, and then relax. I can even stand up and kind of increase that abduction, push down again, and relax while doing soft tissue. It's a nice kind of combined technique. And then do that again, push and relax. Now another technique you can add on is called a scapulothoracic myofascial release. You essentially frame out this triangular scapula, grasping the medial border and the superior aspect on the spine of the scapula. And really you're checking through ranges of motion, right? So we have clockwise, counterclockwise rotation, medial lateral glide, superior, inferior glide here. And you can stack those into a myofascial release, or you can do soft tissue as well. So these things all work really well for the scapula here. All right, now let's talk about the clavicle. So let's have you lie on your back here. So for clavicular motion, just like shoulder, you're using the arm to induce clavicular motion. Because again, the only attachment from the arm to the skeleton is the clavicle. So that's the only bony articulation. So what we have is clavicular flexion combined with shoulder protraction, clavicular extension, which is shoulder retraction. Then we have clavicular adduction, and then we have clavicular abduction. You want to come up here so you can focus right here. So here, right? So again, it's flexion, extension, adduction, abduction. Then we have external rotation. Pretend this is a clavicle. So with external rotation, kind of rolls slightly posteriorly, and this AC joint goes a little backwards, and then for internal rotation, it rolls anteriorly and comes into a little bit of flexion. So again, this relationship between the SC and AC joints, it's this seesaw motion, right? So if he has adduction, this SC joint will start to shift superiorly a little bit. If he has abduction, then that SC joint will go inferiorly. If he has clavicular flexion, that SC joint is going to go posterior. If he has clavicular extension, that SC joint is going to go anteriorly. And then that's how we use the arm to change motion at the clavicles. So again, I'm always monitoring at the distal clavicle, whether it's here or here. Then if he is, let's say, in an extended dysfunction, bring him into flexion, and I just say, bring your shoulder to the floor. 3, 2, and relax. Do that again. 3, 2, 1, and relax. And now if he is in a flex dysfunction, we bring him into extension. So I bring him down like so. That's why I have him come off a little more. His shoulder is off the table so that we can get more retraction of the scapula. And then this is clavicular extension. So to flex it, I'll have him elbow the ceiling. Okay. Yep. And relax. Add a little more force down. Go up again. 3, 2, and relax. So that is, again, 3 to 5 times, 3 to 5 seconds. But that is treating a flexion dysfunction of the clavicle, bringing him into extension, having him flex. All right, so now we have flexion extension for AB and adduction. Let's say you can go back on the table for abducted clavicles, right? This can happen if you're a medical student and you're studying too much and your trap just gets super tight and you're stuck like that. You bring the shoulder down, and I can have an assist with my hand here, kind of pulling. You can control with the forearm near the elbow. Try to shrug your shoulder. 3, 2, and relax. So again, this is for an abducted clavicle, bringing him into adduction. You can go again and relax. One more and relax. And then if it was stuck down, see this in football players or someone who impacts into the shoulder, maybe they have an AC joint separation of some sort, then you can actually bring them up into their barrier and then bring your elbow to your feet. 3, 2, and relax. I'm just monitoring here. There's no need for me to push like the last technique. Go down and relax, just like that. And then for internal external rotation, I'm gonna actually utilize my knee here just as a bit of a fulcrum. And I'm gonna swivel this way. So monitoring here, let's say he had an internally rotated clavicle. I would externally rotate here You can even have your force here or here. And I would just be careful, because this is an apprehension test in a way. If he has a dislocation preference here, you've got to be very careful, or if they're hypermobile, be very careful. So I'm monitoring the distal clavicle, and I'm going to say, try to throw like you're throwing a baseball. Do that, and relax. If I need more, bring him into a little more, go again, and relax, and again, and relax. If it is an externally rotated dysfunction, bringing him into internal rotation of the clavicle like this, and then try to use your fist to go behind you like that. So do that, 3, 2, and relax. And do that again, 3, 2, 1, relax. And one more, and relax. And then to reassess, just like the shoulder and the clavicle, bring them through active and passive range of motion, feel for any tissue texture changes, any asymmetries compared to the other side, and tenderness. So checking TARC criteria to reassess that. I think that was it.